is going back to my old Mac. I'm thankful I always save a computer. Okay, so we're going through the joints, and the joints, of course, are going to be the functional spaces up here where two bones articulate with each other, okay, a joint. This is an elbow joint. All right. So they're going to bind the skeleton together, and this actually also will incite sort of bone growth because you're having interaction. So it stimulates activity going on between the bones. We're going to see that the hormones will interact with the bones. They'll allow things like a little widening of some of the fibrocartilage at the pubic symphysis and childbirth so that we can open up our birth canal. And it's just going to work along with the muscle contractions in the nervous system to allow movement to take place. So we have three different kinds of classifications for bones structurally. You can classify them structurally or functionally. Some books go through both. Your textbook really goes through it by structural function, and then it throws in some of the more functional physiology classifications. So that could be a little bit confusing. All right, so we start out with our fibrous joints. These are going to be joints that are held together when the bones are in close contact. And so you'll have these big bands of fibrous collagenous tissue holding them together. You'll also have cartilaginous joints. And these are going to be more the joints that we'll be somewhat talking about, which are going to be hyaline cartilage, holding and connecting the bones together. And the biggest category that we save for last is our synovial joint, which is going to be most of the joints in the body. And these are the joints that allow for the freer movement that we think of when we think of joints, okay? And all synovial joints will have three basic components, which is going to be articular cartilage at the ends of the bones. So your bone tip up here, this is the head of the humerus, will be covered with articular cartilage, all right? And then a joint capsule surrounding the entire joint. So you'd have a joint capsule right here around the whole joint of the elbow, all right? And a synovial membrane. And that synovial membrane, it will be a little bit confusing as we get to it because they kind of separate it out from the joint capsule. It's really a part of the joint capsule because it's the inner lining of the joint capsule. Okay, so your book kind of puts it out as there's three parts of the synovial joint, but you really could put it as two parts with emphasizing the inner membrane lining of that second part. Okay, if we also want to classify them functionally, you're classifying it by how much movement the joint allows, all right? So you're going to have the completely immovable joints, which are the sutures in the skull, okay? And these are called synarthrotic. Anything arthrotic, arthrosis, is going to be referring to joints. So when you see things like arthrocentesis, it's going to be putting a needle in a joint and withdrawing the fluid. Arthroscopic, putting a scope in a joint, all right? Synarthrotic, syn means together, so it means immovable joint, all right? Amphiarthrotic is slightly movable, okay? So amphi is also kind of like like amphibian, right? Can be on land and can be in water. So amphi is slightly movable, somewhere in between the synarthrotic and what we get to next, the diarthrotic. And the diarthrotic basically is synonymous with synovial joints. It's functionally classed as freely movable. All right. We'll start out though, since we're going with structural, and we'll go through this way. The structural ones we'll start out with are our fibrous joints, and it's going to be named such because of all that dense connective tissue that's holding them together. And so this is bones in close contact. And this would be things like the sutures in the skull. That's the one we're already familiar with, all right? There's 3 types of fibrous joints: the syndesmosis, the suture, and the gomphosis. I told you there's a lot of vocabulary. All right. So your syndesmosis is going to be bones that are bound by a sheet of dense connective tissue. And these will be like your radius and your ulna held together, or your tibia and your fibula held together. And they're held together in a compartment by having a dense fibrous tissue running between the 2 bones. So the bones do not move separately away from each other. Now the joint is a little bit flexible. It's more flexible than a suture in that it's got that dense connective tissue that has a little bit of flexibility, so that when you're having a twist, like, you have a twist on your leg or a twist in your arm, there's going to allow a slight bit of movement. And since it's a slight bit of movement, somewhere between no movement of the suture and the free movement of a synovial joint, then you have an amphiarthrotic joint. Okay, so between the tibia and the fibula, between the radius and the ulna, these are pretty much the only 2 syndesmotic joints that you have in your body. All right, then we have the fibrous joint, which is our suture. And these are where our bones become interlocked. And you all know this one because we were looking at the skull, and I know you all have been super busy, doing all your homework, right? So the immovable joint is going to be things like the picture up here of the lambdoid suture, and you see the sagittal suture arising over here. You have your 2 parietal bones, and right here you see this little bone in the middle, and this little bone kind of with all these sutures surrounding it. This is a picture of the Wormian bones that we talked about before, and we didn't have a good picture last time. So when you have a little island of a bone sort of arising in the midst of the sutures, and you usually see them right here around this juncture of the sagittal and the lambdoid sutures. All right, but you can see that these are pretty well knitted together, and they aren't going to move in the adult skull, okay? So that is the sutural joint. All right, and the last type of fibrous joint is called a gomphosis. And a gomphosis is basically going to be your tooth socket. And your tooth socket is a fibrous connection. You have your periodontal ligament that's going to bind your teeth in those alveolar sockets into either the mandible or the maxilla. And so you see that right over here, how you have this periodontal ligament binding it right inside of the socket there. Okay, so the only place you're really going to have a gomphosis is going to be with the tooth. Okay, when we go on to our cartilaginous joints. In cartilaginous joints, you're going to have first type is called a synchondrosis. Okay, so again, join together tightly with the word syn, chondrosis, cartilage. So it's a rigid hyaline cartilage bridge that is in between the bones. And we've seen this when we looked at the bones and we saw that epiphyseal cartilage laying at the end of the bone between the diaphysis, the shaft, and the epiphysis, right up here. And you have that little growth plate in there. And that growth plate is initially cartilage and flexible, but it will eventually become grown over and become synarthrotic as the bone matures, okay? All right. The other place that you see a synchondrosis is the attachment of the first rib to the manubrium. The manubrium is that top of the sternum, the shield point, and that too can close off pretty difficultly, and you will have a synarthrotic joint, okay? A synastosis joint is when you have completely fused bones that become immovable or synarthrotic, okay? And this, an example of this would be another one of the sutures of the skull, the metopic suture of the skull. And as I said, with synchondrosis, when that epiphyseal line grows over totally completely, and it's non-cartilaginous, so allowing no level of movement at all, it's going to be forming then a synostosis. It's closed over with bone. All right. And then the last cartilaginous joint is...
I'm sorry to ask, for the synostosis, you said sometimes it can close up. Is that normal or no?
It's normal. It's not sometimes it closes up. It should close up developmentally. Okay, so all of your, and we'll get to that. I'll show you some x-rays later on in the lecture, and hopefully you'll get that a little bit more understanding, okay? When I show you the x-rays. That's part of why I show you the x-rays. All right. The last cartilaginous joint is the symphysis, okay? And these are going to be bones that are covered with a thin layer of hyaline cartilage, and then they're going to have a connection of a pad of fibrocartilage between the bone. And this will allow some limited amount of movement. So our pubic symphysis, which you see down here, and we'll have some bigger pictures later on, you have a little fibrocartilage disc in between the two bones. And as I said, the hormones during childbirth will soften this connection here, and you can widen out the pubic symphysis a little bit when women go through childbirth, okay? So you get that baby with that big head out of the birth canal. The other place that we've always seen it and know already where we have fibrocartilaginous discs is in our vertebrae, right? So you have your fibrocartilage disc, all right? Limited range of movement. You have some ability to move the bones against each other because you can obviously bend your spine, right? You can bend it a little bit sideways. You can bend it a little bit backwards. You can bend it a little bit forwards, okay? And this is where I would have you play with it too, because one of the things I found is somehow in studying, students mess up in their minds the orientation and forget that this is the anterior side or the front side that faces all your abdominal organs, and this is the back side where all those back muscles attach. So when you're bending forward, flexing like that, you know, all these bones kind of go this way and you're expanding out all these spinous processes from each other. When you arch your back backwards, you can see how much more limited it is by all those spinous processes going together, all right? Okay, so that is a symphysis between all of the discs of the vertebral bodies. And the big one that we'll be spending time on is our synovial joints. And our synovial joints would be like here, the joint at the elbow, okay? So you have your elbow joint, okay? You have this, this is looking from the bottom up of the ulna. Here, if I put the humerus up here, and you can see how it's freely movable, how the humerus will rotate into this trochlear notch on the ulna. I unfortunately don't have a radius, or I couldn't find the radius in my bone box to show you that. And it's freely movable. It's going to have articular cartilage at the ends of all those bones. That articular cartilage is going to be primarily hyaline cartilage. And you're going to have it surrounded by a joint capsule, okay? Within that joint capsule, okay, if we discuss the capsule, there will be two linings. And I think let's go on to the next page, but let's just look here at this is an idealized joint, okay? Whoops. Sort of an idealized joint. You have the ends, okay, the two epiphyses of long bones here. So they're filled up with spongy bone and they have their compact bone overlying it. Then you have articular cartilage at the tip of each bone, okay, where bone meets bone, articular cartilage. Now, holding these two bones together, you'll see you have this big fibrocartilaginous capsule, okay, this big fibrous capsule. And within the fibrous capsule, you're going to have an inner layer that will be called synovial membrane. And this is this blue outline out here. Then you have the space that is the synovial cavity. And this synovial membrane, you will find, will be creating the fluid that will be a transudate from that synovial membrane that is set out in the cavity that lubricates over those joints, okay? All right, so here's Jaden's favorite picture, right? The diagram of the knee, all right? So Ashley, this is where you see that growth plate, okay? That epiphyseal cartilage right here. Now, the younger your bone is and your bone is still growing, it's much more cartilaginous. But as you get older, it will close and form basically a bone scar line where the cartilage used to be, okay? All right, now the knee is a lot more complicated, and you'll see we get some complicated structures when we get into some of our big synovial joints like the knee, the hip, and the shoulder, classically. All right, so we have our two bones. You have the femur coming down with its spongy bone covered by compact bone, all right? Meeting up here with, we're showing the tibia, the big bone of your shin is your tibia. Again, with spongy bone covered by compact bone. And then you have at the tips of each one, a layer of articular cartilage just surrounding the tips, basically from epiphyseal line to epiphyseal line, okay? Now, covering over that, you have your fibrous capsule, right? Fibrous capsule is going to cover the whole synovial joint. And here is covering out here the synovial joint that will contain some other things like a fat pad, another fat pad, okay? And then the inner lining of that fibrous capsule will be your synovial membrane. And that synovial membrane is going to leak out synovial fluid all throughout the knee joint that will bathe over all the parts of the joint to keep it lubricated and nourished, okay? Here in the knee joint, you'll see you have another bone coming into play, which is the patella or your kneecap that can slide back and forth a little bit. You'll have a ligament that comes down holding it to the femur, the femoropatella ligament, okay? You also can see that you have these little pads called bursa, and bursa are lined also with synovial membrane, and they contain synovial fluid. And we'll find that on sort of bony prominences, you will have bursa to kind of lubricate and smooth over where you're going to have ligaments and tendons needing to glide smoothly over bones. All right. Okay, so let's talk about the articular cartilage that's at the end of our bones, of our synovial joints. So inside that articular capsule, you're going to have at the tips of the bones articular cartilage, and it's only about 2 to 4 millimeters thick, probably closer to 4 on you guys, closer to 2. In some of my bones, there's probably next to nothing at all in my hip bones. All right. It's a specialized type of hyaline cartilage that's going to have a lot of water content. And holding in that water content will be some of those big proteoglycans, specifically hyaluronan in our synovial joints. They work like kind of like little spongy bottle brushes that hold in lots of water and keep it kind of like your synovial fluid, like a thick egg white type of consistency. All right, kind of more gel-like. Your articular cartilage is going to be devoid of blood vessels, lymphatics, and nerves. All right, the nerves are out to the side, and this was the error I made before, and why it hurts so much is coming within that actual fibrocartilage, but not actually covering the tips of the joints themselves. All right, and this articular cartilage has a very limited capacity to be repaired. So as it gets worn down over time, ultimately, we all end up with some osteoarthritis as we age and we wear off our articular surfaces, okay? Hopefully you wear it off, you know, more slowly than what mine are wearing off. All right, so all the internal surfaces of that synovial membrane are going to be covered by all the other interior surfaces that are not the articular cartilage will be covered by synovial membrane. The articular cartilage itself is not covered by synovial membrane, but it will be bathed in synovial fluid. So every surface inside of the joint capsule is going to be bathed by synovial fluid that's secreted by that synovial membrane. And that's what will nourish that avascular articular cartilage. It will get all the nourishment from that fluid that's bathing it. Has to take it up by diffusion. Okay, so the joint capsule has two layers. We have the outer layer that's fibrous. So that's going to be made of dense connective tissue. And this is going to be continuous with the periosteum that will invest the bones. Remember that periosteum has those Sharpie fibers that we discussed, and it runs into the bone itself to tether it to the bone, but it will also send those fibers out to tether into the muscular tendons, all right? And that's what kind of sews it all together. Okay, and that's going to be continuous, again, with the fibrous capsule of the joints. And this is going to completely enclose all the parts of the joint, but allow some flexibility so that our joints can move. So we can't tether it down too tightly. Our joint capsule is also going to be stabilized by all the different ligaments that run around our joints, kind of putting like bands of stabilization, almost like what you do when you want to stabilize your joint externally and you put on one of those elastic sleeves around your joint that you always see people wear to keep it a little bit more stable. Your ligaments serve that same purpose running around your joints, okay, with fibrous tissue. Now, the inner layer of that joint capsule is going to be synovial membrane. And this is made out of a connective tissue that doesn't have a basement membrane, and it's only going to be a couple of cells thick. And it's going to have its job is going to be secreting all of this viscous synovial fluid, okay? The synovial membrane is only 2 to 3 cells thick, and it's going to be sealed in that capsule from all the outside tissue, okay? And it will, that will prevent it from when the joints move and squeeze, that it doesn't squeeze down and extrude. I thought I stopped that clock, sorry. It will, you know, when your joints move and run and exert pressure against the two bones, you don't want it to squeeze down on that synovial fluid and squeeze it out into the surrounding tissue, like the muscles, right? That joint capsule actually keeps that fluid from going outside of the joint capsule. It contains it within the joint capsule. So when you're running and you have all that pressure as you hit the pavement, it still stays in there, that synovial fluid, doesn't get squeezed out, and will then cushion the action of bone against bone. All right. Now, just beneath the intima of all this synovium, you're going to have some fenestrated blood vessels. Fenestrated means they have a lot of little gaps in it, and those little gaps will allow the blood to leak out some of the nutrients that the whole joint capsule needs, okay? And this is going to provide the nutrients throughout that synovial fluid for things like the articular cartilage that has no other way of getting nutrition except through all that synovial fluid that's going to be bathing it. You can also have a lot of villi. Remember, we have our villi increasing the surface area. Some of the synovium, especially the younger it is, will have a lot of villi that will help the soft tissue change shape as the joint surfaces move against each other. Okay, so that increases the surface area of the synovium. And your synovium is going to be rich in type B cells, which are a type of fibroblasts. Sometimes they're called fibrosynovial cells. And these are the cells that will secrete hyaluronic acid, also known as hyaluronin, okay? And this is the stuff that confers that thick, lubricating quality to the synovial fluid. Okay, so remember hyaluronin is that thick proteoglycan, sometimes called a glycoprotein, depending on where you divide what's the protein content of the molecule versus the carbohydrate content. But regardless, it is a protein that has a lot of carbohydrate attached to it. Looks like a big, thick bottle brush, okay? And this is what the fibroblasts-like synoviocytes, known as the type B cells, will secrete, okay? And in the knee joint, for instance, your book says it wrong. Your book says you only get a 0.5 milliliter of fluid in your knee joint, but it's more like 3 to 6 milliliters, probably closer to the 6 milliliters at most ends. I actually spent some time looking it up last night because I saw some variation in the amounts reported. But they do all these studies and it seems to be closer to 6 milliliters, okay? The functions of our synovial fluid is going to be to lubricate the surface. It's going to create that nice slick surface. It's basically the KY jelly of your knee joint, right? Okay. Nutrient distribution is going to supply all the nutrition from those fenestrated capillaries that bring in all the nutrients to the synovium, and it's going to circulate it around that whole joint capsule, bathing your articular cartilage and other parts of this synovial capsule such that everything gets the nutrients that it needs. And the other big thing is with having all that water, with that gel-like consistency, the consistency of the extracellular matrix will allow you to bear stress on your joints without having permanent distortion of the joints. So therefore, it's a shock absorbing quality. Now, a clinical correlation your book comes up with this is the concept of arthrocentesis. Arthrocentesis is basically an in-office procedure. You swab down let's say you're doing an arthrocentesis of the knee. I don't know, did you have one of these, Jaden?
Mine was arthroscopic.
You had arthroscopic surgery. They didn't do any centesis ahead of time. So this is usually something they sometimes do before you go on arthroscopic surgery. Now, Jaden is young. I think and I'm sorry if we're talking about your surgery and you don't want.
Oh, please do. Please go for it.
So you had an injury, right?
Condition, injury.
Yeah, he has a genetic propensity for things to go wrong, and then probably injured it, and then he ended up having to have knee surgery. So he went straight to arthroscopic surgery. Older people probably will get arthrocentesis first, where we're going to aspirate. So you stick a needle into a joint capsule, you withdraw some of the fluid, and you can look at some of the fluid in office, and you also send some out to get evaluated in the lab. But we can tell maybe what's going on in the joint by just looking at the fluid. Is it bloody? Probably then the reason your joint is hurting so much is there's been trauma to it. Something's happened to it. If we look in the office and we withdraw out and you get this kind of cloudy yellow fluid, oh my God, probably maybe you're somebody who's going to have some rheumatoid. And we're going to send off all of this fluid to get it evaluated to see if you have rheumatoid factor and other things that all the rheumatologists love to look at for treating rheumatoid arthritis. You can look in there and see if you have crystals, in which case you might have gout or what we call pseudo gout, depending on which type of crystals. And we look under the microscope, and this again is in office. You can see under the microscope if there's these birefringent crystals. Or if it's really cloudy and has profuse pus in the joint, then you have a bacterial infection. And, you can have arthritis from untreated sexually transmitted diseases are one of the common arthritises that you'll find this way. So you can have people who have a gonococcal infection of their joints, okay? So this is another reason to treat your sexually transmitted diseases, because a long-term consequence can be the spread of these things through the blood into your joint capsule, and it tends to settle in your joint, and you end up with gonococcal arthritis. And I got a long story about that one with a bad in-office physician that I'll just say it shortly here. When I was in medical school, we got placed out in local physicians' offices, and I had the first time I ever saw a joint arthrocentesis. He was doing an in-office arthrocentesis in his office, and it ended up being a gonococcal arthritis that he aspirated from this guy's knee. And then the next person to go in that room and sit down up on the table was a pregnant woman, and he had no nurse or nurse's aide or medical assistant who was cleaning off the tables or anything like that in between the exams. So I, as a little medical student, at least kind of had an awareness of all this. And I'm in there and I started like bleaching down everything before this poor pregnant woman was going to be examined in office and have a pelvic examination on that same table where he just drained gonococcal arthritis. Now, in our era of COVID, I hope you all have an understanding of how serious this was. And I actually ended up reporting this doctor to the people at my medical school because I was just flabbergasted by this. And he was kind of like maybe an old-timey doc who was a little bit losing it. He was a nice man, and I felt terrible having to report it. But, it all has to be about patient safety. It can't be how much you like the person. It can't be, anything. And honest to God, nurses are sometimes the best whistleblowers, the saving graces. Remember how we all had this cancer doctor here in Detroit a few years ago that you all were probably hearing about, who was billing millions and millions of dollars and giving people cancer treatments that they didn't even need because they didn't even have cancer. His name was something like Dr. Fatah, something like that. And it was a nurse. It was the nurse who blew the whistle on him. So, you guys are often the vanguard of safety, all you nurses out there. You radiologists can be too. You can catch things on radiology that's missed. So take that responsibility very seriously. The checks, just like in our government, the checks and balances of all of us watching over each other has to work. I mean, I think the first thing is, if it's a simple problem, is always address it, be an adult and address it with the person. And maybe they just had a momentary brain lapse, that ordinarily they're good. Anyone can have an off day and forget to do something that keeps someone else safe. And you kind of know over time, if you're working with people, you get to know whether somebody continually has problems and you think they're a hazard versus, somebody who's ordinarily good is having an off day and you just have to say, whoa, wait a minute, calm down, think things through, okay? And this is where you will learn all these checkpoints that we've actually adopted in hospitals from the airline industry, okay, of going through. And this is why we have the obsessive things that you have to take very seriously, of double checking the patient name, double checking the procedure, double checking what, limb is it going to be the right limb or the left limb? And everybody in a room has to agree on it. And I'm not even just talking about the OR, I'm talking also about on the floor. All right. So, and these things should translate to our in-office practices as well. My sister last week last week or 2 weeks ago, had to go and have a colonoscopy My sister's name is Karen Prather, and she went in to check in for her colonoscopy and at Beaumont Hospital. And someone said, "Oh, I already checked in Karen Prather." And then everybody at the desk got freaked out and said, "Oh, no, this is Karen Prather checking in." So then they thought they checked in the wrong person. Turns out there were 2 Karen Prathers getting checked in for colonoscopies with the same physician back to back. What are the chances of that, you know? And so the girls at the front desk at Beaumont Hospital they called up the GI doctor's scheduler and said, "Do not ever do that to us again. Do not ever schedule 2 people with the same name in back-to-back appointments on the same day." It caused like 45 minutes of chaos as they all had to clarify everything that was happening. And, and then of course, I'm sure it would cause chaos down in the pathology lab too, as any samples taken from that colonoscopy would go down there, and then they're all going to be on high alert not to mix them up. So safety checks in place really prevent bad. I think it was Jake last time asked if these kinds of mistakes happen. Yes, they do. We do M&M conferences, and this is one of these things that we always go through. People could sue us a whole lot more than what we are sued. People don't really even know half the accidents that happen. And this is, if ever you get the opportunity to go to an M&M conference, it's a really eye-opening experience of seeing where our systems fail us. Okay, moving back on from that aside, on our synovial joints. So we sometimes have accessory structures in our synovial joints, all right? And our knee is famous for this. So accessory structures that we can have will be excess cartilages and fat pads in our synovial joints. We can also have ligaments and tendons that can run through our synovial joints or around them, and bursa within or outside of our synovial joints. Boy, that sun keeps coming in. I look like I'm like holy or something up here. Okay, so talking about the cartilages. So you can have articular discs or menisci, a meniscus is the singular version, okay, within a synovial joint. And the knee is famous for this, as I said. The meniscus will basically divide your synovial joint into 2 compartments, like in the knee, above and below the meniscus. And these are thin plates of fibrocartilage. And I'll talk mostly about the knee because that's where we know about it in detail, is that they'll attach to the fibrous layer of the joint capsule out at the periphery, okay? And then they project their free surface into the central part of the joint cavity. And that meniscus will work to help stabilize the joint, cushion the joint. It'll help distribute the weight across that joint capsule. When the articulating surfaces of the joint are a little bit incongruous, and especially there in the knee, because you have 2 lower bones joining up with that one big, more proximal bone, it kind of helps both distribute that and kind of cushion that bumpier surface of a couple of bones coming up there. And so those meniscus will also aid in directing the flow of that synovial fluid to the areas that are going to experience more of the friction. You can have fat pads in the joint, and this will be localized masses of adipose tissue. And these tend to more often be superficial to the joint capsule, but you can have sometimes a little bit of fat pad extending into the joint capsule. And these will serve to protect those articular cartilages that are at the ends of the bones. And then of course, our ligaments, our capsular or intrinsic ligaments, you can have some of those, but more often we see the ligaments, like I said, that are external that will bind around and keep our joint a little bit more firmly bound to each other. It will reduce the mobility somewhat, but it keeps the joint more stable. Now let's talk a little bit about these capsular or intrinsic ligaments. You'll see this in places like in the hip. Okay, when we get to the hip, I'll point it out. There is a ligament that runs in the hip called the ligamentum teres, and it will run from a little exposed area of the fovea that doesn't have articular cartilage on the femur, and will kind of tether it into the acetabulum or the socket. And that joint kind of helps stop the movement of the bones around in the joint. All right. In the knee, another one that runs through the actual joint is the dreaded anterior cruciate ligament. Why do I say dreaded anterior cruciate ligament? Any of you are football fans? What's always taking everybody out in a football game? You get a nice good side tackle. Yeah, you get a nice good side tackle right into the knee, destabilizes the knee, takes out that anterior cruciate ligament. And when you look at the structures of the joint in the knee, you can see why. It's called a cruciate ligament because it kind of crosses over. And if you get a nice side lateral hit, you can see how that's going to pull on that and detach it. Okay, so the ACL. Even though we think about it so often in football players getting that side hit, it actually affects women more often in real life. There's a little bit more laxity in the joints, the knee joints of women. Okay. All right. So other things will be our tendons. Remember, our tendons will attach that fibrocartilage to the muscles. So it's not part of the joint, but these tendons can pass around the joint and usually provide some mechanical support and will limit the range of motion. Okay. And again, those can also get injured and cause laxity. And a big thing is going to be bursae. An infection or inflammation of the bursa is bursitis. Okay, and that can be very, very painful. And we will draw synovial fluid sometimes out of really enlarged bursa, but they always fill right back up, or about 75% of the time they fill right back up. So these are going to be little pockets or pads of kind of like fibrocartilage that have a synovial lining, and so they contain synovial fluid. These are either connected to the joint cavity sometimes, or sometimes they're completely separated from it. Sometimes you will find people who have mechanical faults or defects in a joint, and they might grow extra bursa, okay? So bursa, there's a lot of variation, but these will cushion areas where our tendons and ligaments cross over or rub against the bone tissues. So like out on your hip joint, you have your greater trochanter, and you'll see as you learn the muscles that we have all these big, strong muscles that come down the sides of our hips, the tensor fasciae latae and all this long tendons. And you will have bursa that are out there covering over your greater trochanter. And greater trochanteric bursitis is probably the most prevalent inflammation of the bursa that you get in the body, and it's often treated with steroid shots to take down the inflammation. Okay, these, like I said, are located around almost all synovial joints. We'll see today there's lots of bursa in your shoulder as well. And adventitious bursa are the bursa that I just spoke about that will develop in abnormal locations because you're getting abnormal stresses. Maybe, maybe something happened and you have developed one leg shorter than the other, and so you walk with a limp. So you might develop bursa in some places that normally you wouldn't have had them, okay, because of the continued friction over time. All right, so some general principles about our synovial joints. The more mobile the joint, the weaker the joint. In other words, we sacrifice our stability of the joint in order to get mobility. And our most mobile joint is our shoulder because we're upright and we use our arms and our hands to do the business of our life. So our shoulder is our most highly mobile joint, and it is our weakest joint, and it is therefore very much prone to injury, okay? All the factors that will stabilize our joints are going to be things that will prevent greater range of motion, okay? So all these ligaments, these dense collagen fibers prevent more motion, okay? So it's always going to be a little bit of a seesaw. More motion we want, less stability, right? Okay. All right. Here again is the idealized view of a synovial joint seen from a lateral view or through a sagittal section. Again, you can see how you have this nice firm joint capsule, okay? That's going to limit the range of motion, all right? You can see the stronger that is, the more limited our range. Again, looking at the knee, you can see in here everything that we have going on the knee. I like this view. You have the big femur bone coming down on the tibia. Obviously, you can't see the fibula because we're looking here from the medial side, I guess, of the lateral sagittal section. All right, and you can see you have the strong joint capsule. You can also see you're going to have all these muscles and tendons from this muscle. You have your big quadriceps tendon inserting on your patella here, which also is continue with your patellar tibial ligament right there. You can see you have little bursa in between these ligaments. So you have this nice extracapsular ligament out here, patellar tibial ligament, and you have bursa on both sides of it because you're going to have this sliding, your patella kind of slides up and down in this tendon sheath over in front of both your femur and your tibia, depending on your position. And so you can see how many bursa you need to have around that to help make that sliding motion a lot more comfortable. Okay, our synovial joints, prone to injuries because of their mobility. What's the main injury? Dislocation. One bone gets knocked out of joint from the other bone. And this is often called luxations, okay, when we dislocate it, okay? And dislocating your joint can cause rubbing on the articular cartilage and wearing down of that, right? So it can damage your articular cartilage. It can also damage and stretch the ligaments, the joint capsule. More often, we have partial dislocations that we call subluxations. Now, as soon as we get into the term usage of subluxation, before I go on to the next slide, any of you ever hear of the word subluxation before?
Nope, it's hard to say.
Yes. It is a term beloved by chiropractors, okay? And we are now going to get into a little aside discussion of the turf war between chiropractors and doctors here. And I will tell you that chiropractic, in my opinion, is a whole bunch of hooey, okay? And
Disagree. They have helped me numerous times.
yes, okay. I would question how much they've really helped you and how much of it's a placebo effect. People like to go to chiropractors because they pay attention to their patients. But the whole premise of what chiropractic care is based on is fabrication. And this is where you get an understanding of what is science and what is pseudoscience. And they attribute everything and all pain, and they attribute infections, everything that goes on in your body, to subluxations or dislocations of joints that put pressures on nerves. And in the opinions of chiropractors, it causes everything from autism and psychosis to joint pain. And they are rife with selling people things like magic water. You know, they sell people water cartridges that are supposed to make change the pH of water so that you're drinking basic water instead of acidic water or something like that, I've heard. You can look at on a lot of chiropractic websites. They sell all kinds of supplements and vitamins and things that don't work. And, you know, part of what they do is they keep patients coming back. And patients say, oh, it works because basically you get a little massage and it feels good while you're in there. And then you come back for more. And then you want more and more, but you're never going to get cured or fixed. Okay. So here's a little thing about what a lot of these chiropractic boards and what they believe all this and lead patients to believe they're going to cure. So I really say watch it. Now this is old data. This is from 1997. I can tell you right now that the average minimum GPA to get into medical school is about 3.71. But all these are probably a little bit higher now because everything is a little bit more competitive to get in. But chiropractic has the lowest GPA requirement to get in, and half of them don't even have a bachelor's degree before they get in. They probably do now, more so. And they are the highest defaulters on their student loans as well. Very expensive to go to a lot of these private chiropractic. It's not very well monitored. At some point we'll get into some more discussions if we have time, but this class goes by fast about a lot of the pseudo science fields that enter medicine, that if you adhere to scientific study and principles, as you should in nursing, radiology, medicine, any of these fields, you're going to be running up against a lot of fallacious arguments. You know, people like to argue that taking herbs and all these things that they can buy, like I said, at GNC or whatever, is healthier and better for them than taking pharmaceutical drugs. And I am no fan of the pharmaceutical agents, but I am no great fan of the GNC people either. I think people are always trying to sell you on something and trying to turn a buck. At least with the pharmaceutical agents, they hopefully have to go through the FDA and pass rigorous testing. You know, today's FDA, I'm a little bit is a little bit on shakier grounds with the Trump administration, in my opinion, because he keeps putting in his cronies and trying to help out the pharmaceutical agency. But you know, I'm scared about this passage of this new vaccine that they keep trying to get out, and that we're not going to have as rigorous testing. And then we'll find years later that there's not a good safety profile on it. But GNC stuff, you have to be really careful. Herbs and berries, there's what's called the naturalistic fallacy, that just because it's in nature, that it's healthier and better for you. And that is just not true, okay? Digitalis is natural. It comes from the foxglove plant, but it will stop your heart, all right? We use it as a medication. We use a lot of things derived from plants as medications. So beware, don't fall for the naturalistic fallacy. Sometime you can write a paper about it and look up things and feel misbegotten that everything that's in the natural world does not mean that it's particularly safe for you to ingest it. Okay.
My mom works for a company who designs medical products, and they obviously work with the FDA. And I think you need to worry about more is the companies who try to get around some of the FDA.
Well, that's what I said. I'm no fan of companies like the pharmaceutical industry or like medical devices that try to skirt the FDA and hide bad data from them. But similarly, at least you have the FDA watching over those industries. What I'm saying is that with the, you know, herbal medicine and all the people who are out there hacking their products on late night TV and stuff, like They have no one watching over them. There's no agency that controls that, all the supplements. You know, people think that because it comes in a bottle and they buy it from a store, that it's been approved as safe by some government agency, and it hasn't been. There's nothing watching over that. All right, so let's get
My
out.
mom's not liked very much because she follows the FDA rules and they don't always like,
Well,
you know,
right.
step by step.
None of the companies that have to have regulations like the regulations. You know, they want to always promote to deregulate the industry. But as I said, we need regulations to keep us all safe so that someone doesn't sell us things that then you find in, you know, implants in bodies that are unsafe, and you find it out 20 years later after you've had millions of, you know, faulty hips or something implanted in people's body that leach out cobalt, which is something that's happened. Okay. We've changed a lot of the, you know, as we get into here, we're doing the hips. So we'll talk about hip replacements, but a long time ago, they used to have cobalt as one of the ingredients that the hips were made out of. And as the artificial hip would grind its parts against each other, the cobalt would leak out into the blood of those who had these artificial hips and would poison them. So the more you walked and the more you ground your artificial hip parts against each other, the more cobalt leaked in your blood and you were poisoning yourself. It's crazy. This is why we need regulation. Okay, so whenever you see politicians always talking about how they want to deregulate industries, always beware. That means someone else is selling you something probably where they don't want someone watching over, whether it's medical parts or whether it's pollutants from the auto industry into our environment, right? Or pollutants into the water in Flint. Okay, so all right, so let's get back to our focus. Synovial joints. We have 6 types of synovial joints, and they're all classified by the shape and how much freedom of movement they allow, okay? So the big ones are our ball and socket joints. This is going to be like your hip or your shoulder, okay? And so you're going to have on these sorts of joints, you will have big rounded heads, right? Big rounded heads at the epiphysis of the joints. This is your humerus, and as it fits into the glenoid cavity of the shoulder, okay, of the scapula, it's going to have a ball fitting into a socket so it can rotate around and have lots of freedom of movement, okay? These are also called spheroidal joints because of the ball end, and they will fit into a cup-shaped cavity. As you see here, you have the head of the femur fitting into a cup-shaped cavity of the acetabulum of the hip. And that acetabulum is going to have all 3 parts of the hip bones, the coxal bones, fitting in there, part of the ilium, part of the ischium, and part of the pubis all form the acetabulum. This allows the greatest range of motion because it allows all that rotation as that ball rolls around in that socket, okay? So it's multi-axis. And so it's our hip and our shoulders that allow us our freedom of movement right at the point where our appendages will attach to the girdle, right? Hanging off of our axial skeleton. The other type of joint will be a condylar joint, and this is also known as an ellipsoidal joint. And this is like what you see at your metacarpals, the bones right here in your hand as they fit into your phalanges, okay? And this allows back and forth and a little bit of side to side motion. It's kind of a biaxial movement, but you can't rotate like you can, you know, I can rotate a little around, but it's gliding. It's not like rotating like a shoulder joint, okay? Biaxial. So between your metacarpals, the hand bones with the finger, all right? Then you have plane joints. Okay, and these are gliding joints. And this really doesn't allow very much motion at all. Okay, and this is going to be like those flat bones, the carpal bones in your hands. They kind of move a little bit to give your hands some flexibility, especially for gripping in that, but it's very, very limited, the amount of motion that you get in your carpal bones. And then you have the hinge joint, which is what you see here at the elbow, right? It doesn't, your elbow, you can't just take and circle around the bones of your lower arm, okay? More limited range of motion. And you will see, as we examine the elbow, right here, I just have the ulna fitting in with the humerus. I don't have my radius up here, with the two bones fit together. And you have this olecranon, it's kind of like a little wrench that fits in here and forms a hinge, like what's on your door, right? And if you think about your elbow, it moves a lot like the hinges on your doors or cupboards. So it's uniaxial in one plane. Then you have pivot joints, and this is like our atlas and our axis. So it's going to allow for rotation, right? And so you have your axis down here that has the pivot point on it, and your atlas will rotate around it. Again, uniaxial, just moving in that rounded motion. Saddle joints are what is going to, the only one place in your body that has a saddle joint is at your thumb, okay? And this allows movement in two planes, sort of, okay, shown over here. And that's at your carpal and metacarpal. So from your wrist to that first joint of the hand. Now, when we look at the actions of the types of movements that we're going to produce, and this is getting into a little bit of our muscles, is we'll talk about the origin and insertions of our muscles, but we need to know this for understanding and describing our movements right now. So an origin is where we talk about the muscle being attached to the fixed point, okay, of the joint. And it will pull the movable part toward the fixed joint. So if I talk about my bicep muscle on my crossing over from my humerus to my ulna and radius, it actually inserts on the radius, which isn't shown here, but it's fixed up here on the humerus, and it pulls the radius in the ulna up to the humerus, okay? It pulls it up like a pulley. So the origin is on the humerus, and the insertion is going to be on the part that it moves, all right? The insertion is on the part that it moves. Now, we're going to learn the movements, and I put a lot of videos up from Dr. Alsup over at U of M, who graciously made a bunch of videos, and she's put them on YouTube and released them to all these anatomy departments to help us all out while we're doing online education, because at least U of M had the resources to have someone film her with all these bones. So thank her tremendously for this. So we're going to talk about flexion. Flexion is when we reduce the angle between two bones. So if I start here and I have my humerus and my radius and ulna, and I decrease the angle between them, I have flexed, okay? Now, if I increase the angle, I have extended. Flexion, extension, okay? All right. And as we learn the muscles, you'll learn that we divide the muscles as into what are often our flexor compartment and our extensor compartment. Hyperextension is when you extend beyond anatomical position, okay? Beyond anatomical position. And I have this note here about how people will talk about how they're double jointed. There isn't any such thing as double jointed. It just means that they have hypermobility at their joints. And that usually means some laxity of the connective tissue. Sometimes this is due to genetic defects in the connective tissue, as in Ehlers-Danlos syndrome. Okay, so here are our movements. flexion, okay? Flexion at the hip, bringing the hip up toward the body. Flexion at the bicep, okay? Or at the elbow joint, bringing the bone closer. Extension is that you're moving the hip joint away, okay? Flexing your wrist, extending your wrist. Flexion and extension of the vertebrae, okay? In extension, you're increasing the angle at the centrum. Now, this is showing the direction out here, but this is where you're increasing the angle between the centrum or the vertebral bodies. Flexion, you're moving in this direction, but you see how you're decreasing the angle between your vertebral bodies. Always confuses people. Other angular movements we talk about are abduction and adduction. And so you go, especially Ashley, like the physical therapist, you will have people working on abductors and adductor groups of muscles, and your adductors will bring things closer to the midline of the body, closer to the longitudinal axis, where abduction is like to abduct something or move it away, okay? Adduction and adduction. So adduction, you're taking everything and moving it back in line with the body. Abduction, you're moving it out away from the main axis of the body.
I really appreciate these words because it's so easy to remember that, like, adduction, you're adding more
Right.
mass to your body, and abduction is like if a UFO was
To
abducting your
abduct you
arm.
away.
Yeah.
Right. Yep. Okay. Abduction, move away. Adduction, add back to the main axis of the body with your hands. And, you know, and you go on these machines, if you go to the gym and it says, oh, you're working your adductors and oh, you're working your abductors. And half the time, nobody understands what they mean. Your flexors, your extensors, all this. But, you know, maybe now when you go in there, you'll pay attention to some of those signs because, you know, we're all going to the gym these days, right? All right. Circumduction is circular motion without rotation, okay? This is better shown by watching the videos, obviously, because you're moving in multiple planes. And rotation is left or right, like rotating your head, okay? Circumduction is kind of moving all around, all right? So you can have medial rotation. So if my head is out here and I medial rotate right back, I lateral rotate away, I medial rotate back, okay? Circumduction, you can see, trying to do on a flat picture here, is moving all around, okay, in multi-axes. Okay, we also have pronation and supination, and this is going to especially be involving your radius and your ulna. So you see here that you have your pronation, supination as it twists over, pronation, supination, okay? And you will see how when you're going from pronation, your radius crosses over your ulna like this. And then when you supinate, they're back kind of more separate. They're held together by the interosseous membrane, but we call it the radius because up here you will see the radial head has a little discus for rotation on it. So it's the radius that kind of crosses over, but always remember your radius, the end point, stays with your thumb, okay? When it's crossing over, whichever way you're moving it. Now somebody was trying to pipe in with a question.
I was just actually going to say something about how I was not necessarily taught the first time I learned anatomy back in high school, but believe it or not, we learned anatomy in beauty school as well. And so my teacher actually had really great ways to memorize pronation and supination. So she had said that pronation, think of like a pro basketball player, okay, palms down, you're, beating a basketball, and supination, like you're putting your hands out forward, asking for soup.
Yeah.
And with the radial, she had said, you use your thumb, you turn the radio up, and then the ulna, I can't remember what it was for the ulna, but I mean, that's just how I've always remembered it. And it's helped me so much. And I I've mentioned it to other friends that have taken anatomy, and they're like, oh my God, that makes so much sense. So
See,
I don't know.
and you're somebody who works well with mnemonic devices. And I will admit right now, I have never been good at mnemonic devices. I like understanding the actual mechanics a lot better, and it helps me remember it. I end up not remembering the mnemonic devices. So I'm not the best one to ask for that, but everybody ask Caitlin if she has mnemonic devices. And some of these videos that I've loaded up for you will say some of them. You can also Google some of the mnemonic devices that people commonly use in anatomy. A lot of them are very dirty, so I can't say them out loud here in, you know, a class. It would be unprofessional. And I know that a lot of people say the dirtier the better, the easier for them to remember. Okay. There's very few of them that I've ever used in my life, just because it's never been a memory thing that works for me. All right. Other movements. Okay. Inversion and eversion. This is specifically for your foot. So you can invert your feet or you can evert your feet, right? So if you're wearing out the outside of the soles of your foot, you're probably everting and putting all your pressure on the outer sole. Whereas if you're inverting and walk maybe a little, oftentimes when you're inverting pigeon-toed with your feet turned in, you'll wear out the inner part of the sole of your foot. Dorsiflexion and plantar flexion. If you pretend this is the foot going up is dorsiflexion, and the foot going down, like if you're going to stand on your tippy toes, is plantar flexion. All right, here is eversion and inversion. And here is dorsiflexion, okay, and plantar flexion. All right, other special movements. The thumb moving towards the finger. It opposes the finger. So bringing your thumb to your fingertips, like for a grasping motion, is opposition. Reposition is going back, okay? You can protract out your jaw and retract your chin in. Protract and retract, like a protractor moves out, okay? Opposition, just like I said. Protraction, thrusting the jaw forward. Retraction, bringing it back. You can elevate or bring up your shoulder girdle, or you can depress it and move it down. Elevation, depression, lateral flexion, bending to the sides, okay, on the vertebral column. So depression and elevation, you can depress and elevate your mouth. You have a tongue depressor, right? To examine the mouth, that you depress the mandible when you ask people to do that. Lateral flexion, just going back and forth, you know, the blonde, I don't know, right? The blonde jokes. All right. All right, so now we're going to discuss some of the specific joints. So the first one we're going to discuss is the most mobile joint, and that is the glenohumeral joint or the shoulder joint. As I said, it's the most highly unstable because it is the highest of mobility, okay? And it is supported by a bunch of tendons and ligaments, okay? And it's going to be where we have our, can you all see this? I'm trying to see. You have the head of your humerus fitting into what is the glenoid fossa on your scapula. So if you look at your scapula, the inside surface of your scapula is all nice and smooth and will glide against the rib cage. The backside or posterior aspect of your scapula has a big spine, so you'll have some muscles that sit above it. You'll have some muscles that sit below it. All right. And then if we look out to the lateral side of the scapula, you'll see that it has the shallow depression, which is called the glenoid fossa or the glenoid cavity. And the head of the humerus will fit in this glenoid cavity. And this will allow the humerus to rotate around in here. Now, if you look at this, and we'll try to get it on camera here, it's really pretty shallow, right? It doesn't really cup over the whole humerus. It's pretty flat on all sides of it, okay? It's pretty flat. And so when that humerus fits in there, you can see how unstable that is because it can slip right out and dislocate the shoulder. And dislocations of shoulders happen and you can pop them right back in and be a real hero. And typically I show people how to do this in class, and it's, but we can't really do that online here too well. So when we look at the shoulder joint, if we look at it from the front aspect, you will see that there's a lot of things that will stabilize it. And one of the big things is all these ligaments and also all the muscles that come in over and stabilize this humerus sitting in this joint. You'll also see, this is the clavicle coming forward right here. The tip of the clavicle will fit right in here to this projection from this spine at the back that comes around and has a tip called the acromion, and it will form this acromioclavicular joint that will have ligaments that help hold that in place, as well as there's a coronoid process out here. And so there will be a coronoid ligament too that comes in. But the big thing that really holds all of this in shape is there's a couple of features. One is you're going to have a little labrum, which is like a gasket, okay, of sort of cartilaginous material that fits around this glenoid cavity and kind of extends it and gives it more of a cup-like shape, that labrum, okay? And this is going to start forming our rotator cuff. Inserting on that labrum that helps hold this in will be the tendons of all these muscles that you see that are cut off here that overlie it. And these are called the sits muscles, and we'll learn those when we get in there. But it's all the tendons of these muscles help hold that humerus in there, and they're called the sits muscles. And we'll pay attention to those when we get into the muscle section. But I want to make you aware of it right now as we're studying this. And they stabilize the joint, okay? So it's a ball and socket joint, okay? It's loose in that capsule, easy for displacement, but we're going to have a labrum that will form all around it. And that labrum acts like a gasket. Do you all know what a gasket is? I don't know. I'm in Detroit, so our engines used to have little cork gaskets that came out of the engines and fit around all the pistons, kind of holding it together to keep all the oil lubricated within. And that's the job of the labrum, is to extend from a shallow fossa, putting some cartilage tissue to make it more of a cup, okay? But a flexible cup, all right? All right, so let's look here. We have our shoulder, the head of our humerus, fitting into the shallow glenoid fossa or glenoid cavity. You have that acromion that comes around off of that spine of the scapula, and it's going to have some ligaments from the acromion to the coracoid process, which is just on its same bone. You're also going to have ligaments holding it to the clavicle, kind of stabilizing the whole shoulder girdle to the main axis of your body. So that clavicle will also be the connection that comes in and stabilizes at the sternum. So you can see how this is kind of holding this all together right here. Now, do you have to memorize all these ligaments? No, okay. Thank God, right? There's a lot of them. But we're trying to get an idea of how these bones fit together, and you just need to know that you have all these ligaments running between all the joints of all these bones to hold it together and kind of firmly tether it together, okay? All right, now looking from the side, when we look here into this whole glenoid cavity, you can see that you're going to have the base of the glenoid cavity, and surrounding it, you're going to end up having this labrum coming out. And it's kind of cut off here, but that labrum really extends out and moves around that whole humerus to kind of hold it in. You'll see underneath all these bones, and within here, it's like right outside of the joint cavity, that you're going to be having all these bursa. This one is below the acromion projection of the bone. And so that'll be the subacromial bursa. Here you're going to have a coracoid because it's below the coracoid process. Here, you're going to have one that is going to be subscapular because it's below the scapularis muscle, okay? You have all these muscles that will be surrounding it and having their tendons surrounding it. The tendons of all these muscles officially form the rotator cuff, okay? And these are your sits muscles. They're called sits because it's the first letter of every muscle. So your supraspinatus, your infraspinatus, your teres minor, and your subscapularis. Your subscapularis is the muscle that comes from underneath. As I said, you're going to have a smooth surface that glides against the rib cage on your scapula. Subscapularis fills in all this. So it's the one muscle that comes in from the anterior side. All the others come in from your posterior side. Your infraspinatus down below the spine, infra below the spine, your supraspinatus above the spine, and then your teres minor is going to be even below your infraspinatus. And you'll see how they come across from the spine on the backside and they tether up like this and tether up and across from above the spine and reach over, and they kind of tether into the humerus and hold it tightly in place. Okay. Hard to do online. That's why I really want you guys to spend some time watching these videos. I think it's a better way of learning it. All right, so that's called the glenoid labrum that surrounds it and extends. The whole purpose of the labrum is to extend the socket, to make it more of a rounded socket, because that glenoid cavity is actually very shallow itself. And then all these processes of the shoulder joint kind of extend from the scapula and help stabilize by projecting laterally, so we can extend all these big muscles out over the shoulder and help stabilize that joint. And they're called the sits muscles. And you just probably need to know the sits muscles stabilize the joint. I don't think you need to know the specific muscles yet because we're not in the muscle section. And you have the bursa that are just named for the bone or the muscle below which they sit. Again, you don't need to memorize that. And this hopefully will show you what I was trying to visualize here. You have your supraspinatus. This is from the posterior side of your scapula, that you have that spine of the scapula extending in the point that's the acromion, that you can feel your acromion out here as that nice point at your shoulders, right? And so you have your supraspinatus, okay? And then below the spine is your infraspinatus, below the spine, and then teres minor. And you see how they come across and form a little cuff of their tendons right around the top of the humerus. And then from the opposite side, okay, of the underneath side of the scapula, you have your subscapularis, okay, just forming the back side all along that smooth surface of the scapula. And this reaches around to the more anterior aspect of your humerus, forming the anterior part of your rotator cuff. So it's all those tendons. Here's another view of it. And hopefully the videos will give you an even better view of some of this. And you'll get more of a feel for that rotator cuff as we get into the muscles. Now, when we move into the elbow joint, our elbow joint is a hinge, okay? And it is now 10 o'clock, so we didn't really get through our joints completely. So we'll finish our joints from the elbow a little bit in lab, and we'll pick up in lab on Friday for those of you who have to leave. Those of you who are staying for lab, shall we just keep going? All right. Yeah. Okay, so let's keep going instead of re-signing on. Okay, so your elbow joint is a stable hinge, and it has articulations involving the humerus, the radius, and the ulna. Okay, and it's the humeral ulnar joint is the larger one. Okay, and at the elbow, your ulna has its large expansion in this trochlea that will have a trochlear notch that will fit around what's called the trochlear process of the humerus. Okay, right there. This trochlea looks like a spool of thread spool. Okay. The radius is normally big down at the thumb, but it's small when it's up here. And if you looked on the ulna, you'll see like a little depression right here. And you could see where a little rounded disc could fit right in here. And the radius rotates against that ulna. It also has an articulation here with what's called the capitulum on the humerus. So the little bump out here on there is where the radius articulates. And the bicep crosses over, all right? Your bicep muscle will cross from your humerus over to your radius, and it inserts on the radial tuberosity. But since the radius and your ulna are attached to each other, when the bicep pulls on the radius, it pulls up the ulna with it. Okay. All right. So there's limited movement on this hinge joint because it's built like a wrench. You can see how this ulna is wrenched literally around the humerus. I have the humerus long bone down here. I'm showing it from up, but you can see how it's like just a wrench. So it has movement really in one direction, rotating around that. Okay. And it's limited side to side, which stabilizes your elbow joint. You don't dislocate your elbow typically. Okay. So the hinge joint, flexion and extension only. And then you have a gliding joint, which is between that capitulum of the humerus, that little part I showed you a projection, and for pronation and supination against the radius. All right. Okay, looking here at your elbow, we're looking at both the medial and the lateral sides. We can see our humerus coming down here, and you can see the coronoid process down here on your ulna, and that will wrench around, and it's covered here with all of these tendons that are stabilizing it at the medial epicondyle. Okay, so the medial epicondyle of your humerus. Here, if we look at the outside at the radius, our humerus comes down and it will have this capitulum that the radius is going to articulate, but you have this annular or rounded ligament going all over the outside of the radius, so you're not seeing it so well here. Let's try to look at some of these. Here shows it a little bit better. Okay, your radius out at the lateral, your ulna at the medial side. This is that trochlea around which that wrench part of the ulna, the trochlear notch, will grind around that. This capitulum is a little bit more rounded. Again, all this is covered with the ligaments, but you have at the top of your radius a little disc that will rotate into a notch, a radial notch on the ulna. And you can see here how this joint forms with this olecranon, okay, notch here on the ulna, fitting into the olecranon fossa on the head, or the tip of the humerus, not the head of the humerus, the epiphysis of the humerus. When she goes through the bones on the videos that I have uploaded, you can see up close better than I can show you here all the little notches. So pay very close attention to those notches on the radius, the ulna, and the epiphysis of the humerus. And it's at this elbow joint. As I said, the biceps will cross over the joint, and you need to cross over the joint to move it, to be able to flex it, to bring that joint up and pull on it like a pulley. And it inserts on that radial tuberosity, okay? And the ulna moves up with it because the ulna is connected in that interosseous membrane to the radius. Okay, moving into our hip joint, we have a ball and socket joint. So you have the head of the femur fitting in here to a socket that's similar to that glenoid cavity, only it's a little bit deeper than that glenoid cavity, and it's called the acetabulum, okay? So the head of the femur inserts into the acetabulum of the coxal bones. And at the acetabulum is made from the joining of all three of the coxal bones of the ilium, the ischium, and the pubis, all right? And it will be covered, of course, in a joint capsule. that will be lined with a synovial membrane and leak out all that synovial fluid. And you have a variety of movements available here at your hip joint, a little bit more limited because you can see the hip socket is a little bit more complete than that of the shoulder. All right, so the hip joint's also called the coxal joint. It's a diarthrosis, which means it's synovial, ball and socket style, and you can flex and extend. You can abduct, move your leg away, or adduct, move it back in. You can circumduct or rotate around at your hip, and you can rotate your leg outward laterally and rotate it back in medially. And all those, again, motions are shown on those videos. All right, so your femur fits into the acetabulum, and just like with the glenoid cavity, your acetabular labrum is completed the socket. So you have another gasket winding around and covering over to complete the shallowness of that socket, making it less shallow. You will also have a ligamentum teres, okay? And this will cross from the acetabular notch over to the fovea of the femur and help tether that femur bone a little bit more strongly into the socket. You don't have that with your humerus into the glenoid cavity. All right, so here we see, this is a cadaver frontal section. And so you can see the head of the femur fitting into the bone here. This looks like the top of the ilium, and down here part of the ischium and pubis. And you can see the rest of the diaphysis of the femur. Diagram probably is a little bit more helpful to us at this stage. You see your ilium up here and the bone fitting into the socket here. Of course, it's all covered up with ligaments. I think I have some better pictures. Here is a picture of the acetabulum itself, okay? You have a fat pad in there in the middle of that acetabulum. And you're going to have all these ligaments that will combine around to form that labrum, okay? So you have this acetabular labrum extending around and sort of making more of a covering as that ball tries to fit in the socket. If it's shallow like this, we now have it covering over a little bit more with the extension of the labrum, helping to hold it in. Interestingly, they found that there's a lot of labral injuries or labral tears in women who do yoga. So yoga, trying to extend too far sometimes can also injure you, all right? You can get labral tears. And a lot of women who do yoga are prone to having labral tears, which will give you laxity of your hip, okay? And if you have laxity of your hip, it can grind down on that articular surface and you might end up with earlier osteoarthritis. Okay, and these are the external ligaments covering over that capsule that will help kind of support and give some, confer some stability onto the hip joint. You don't need to memorize all those. Okay, here again at our hip joint, you have that greater trochanter where you're going to have your big powerful muscles of your leg connecting on here. And here's the bump that's the lesser trochanter. So your greater trochanter is up high, your lesser trochanter down below. Here's your ischial tuberosity. You sit on your ischial tuberosity. If you feel right down now below your bottom and you can feel that spiky little part, that is your ischial tuberosity that you're sitting on. Okay, so we replace joints. As I said, we replace them with synthetic materials. You can have combinations of steel and titanium. Sometimes we use silicone parts in some of our smaller joints, like at your wrist. Hip replacements are the most common joint replacement being done today, and the orthopedic surgeons like to tout the high success rate of that. We're living older and older. Eventually, the older you get, the higher your chances of getting osteoarthritis. And, you know, since we're active people moving around, we end up grinding down our articular cartilage and hip replacements. Almost everybody, if you live to be over 80, you're probably going to either be living with osteoarthritis or you take care of it with a joint replacement. As I told you, some of the materials that we used in the past, we found that they will grind down and leach out things like cobalt was the notorious one in these striker hips that they were recalling. They removed some of them from the people, but once you put in a joint, nobody wants to go back and do a revision and take it out. It's so much more difficult to do the second time around. This is why they also try to put off people having hip replacements at young ages like me, except my hip was broken, so I had to have it, okay? Otherwise, they tell people to wait, depending on what your life expectancy is. You can kind of get an idea of your life expectancy by looking at the lifespan of your parents and grandparents and knowing all your own health issues and health habits. But you know, they say about 15 to 20 years to expect as the lifespan of a hip. I'll tell you too that they will also tell you to be gentle on your hip. I used to be a runner. I am no longer a runner now that I have a hip replacement because I need to preserve that new joint that I have. I can't do the wear and tear that running would put on it. So pickleball, it will now be for me. old lady sports. All right. And they're using 3D, some 3D printers now. And I really don't understand the whole thing with 3D printers. Maybe you guys understand that better. So how we're going to use this for creating joints, I'm not quite sure. All right, so this is what a synthetic joint looks like. All right, so up here you can see this compared to the natural joint on the other side. Here you have a new joint space. As that joint space reduces and the bones come in contact with each other, that's usually the signal for it's time to replace the joints. All right, so they remove the head of the femur, all right, and you implant a new head. And that head is a ball, okay? So you can really see the ball in the socket. They usually also line the acetabulum with a cup against which this will kind of grind. So you put in an artificial cup. So this ball is now put on an artificial neck. And so you've removed the anatomical and the surgical neck of the femur. You leave the part of the greater trochanter out here and you have a little bump of the lesser trochanter. And then you have a whole stem of the hip replacement going down into that marrow cavity of the diaphysis. All right. So you can really see the ball and socket technology that's used when we put in an artificial hip. And people do very well with these generally. Here you can see your ischial tuberosities. This is your pubis bone right here. Your pubic bone comes here and forms the pubic symphysis. Right in here, you would have your fibrocartilage pad. All right. And I like to spend time on the x-rays because this is really how you're going to see the bones, right? You're only going to see the bones from x-rays unless you're in surgery. All right. This is your obturator foramen through which nerves and vessels will pass through the obturator foramen between your pubic and your ischial bones. This is the ilium up here that spreads up to the ala or the wings of the ilium. Right here is about the tip of your anterior superior iliac spine. Anybody guess what this is right here? Do you see this little thing right in here? The shadow?
Is that those birth control things that they put inside your
It's
That
an
is.
uterus.
That's exactly it. It's an IUD, okay? It's an implanted IUD in the uterus. And so you can see where the position of the uterus is within the pelvic bones, right? Right smack dab in the center. So this is where a baby would expand in that cavity. And one of the things you can see on a female right here is that the angle of the ischial tuberosities from each other is greater than 100 degrees, where on a man it's almost right around 90 degrees. And that's one of the ways we tell forensically female bones from male bones. All right, let's move on to our knee joint. It's a complicated hinge joint, and it's going to transfer all the weight of your upper body from the femur onto the tibia below it. So the articulations of the knee joint is that you're going to have two articulations of the femur with the hip tibia at both the medial and the lateral condyles of each of those bones. And then there will also be one between the patella and the patellar surface of the femur. And you're going to have that quadriceps tendon in which basically wraps around the whole patella. All right, so it's, here we have our femur coming down. We've looked at this before. You have your tibia down here, and then you have your patella, and that's going to rest in that quadriceps tendon that kind of encases around actually the whole patella. So that's how that patella articulates with the surface of the femur, is actually through the quadriceps tendon. And it will be strengthened by lots of ligaments and tendons and cushioned by all these fat pads that you see here, as well as these bursa, okay, floating around there. And you're going to have these meniscuses in here, these little menisci. And as I said, part of the lateral surface is going to be connected with that fibrocartilage out here, but you're going to have the free edge of the meniscus extending in here. And you can see how it makes a superior compartment and an inferior compartment. They kind of meet in the middle where the synovial fluid flows around. All right, and this goes through your major knee characteristics. You can look at that on your own. Again, you don't need to memorize all these tendons, but you can see how this anterior cruciate ligament comes out and collapses. And when you get a nice blow to the knee from a, like a side tackler here, you can see how this is going to push over and grip at that anterior cruciate ligament that's kind of stabilizing. And if in your textbook you kind of look around, you'll see how it crosses over sort of more internally from some of the views, but it helps stabilize that knee. You also have a lateral or posterior cruciate ligament as well. Okay, we can't go through all these. Here's all the 7 cartilages. We don't have much time. This shows you how that patella is really encased in that quadriceps tendon. And then that quadriceps tendon really wraps around it and extends and becomes part of these tibiopatellar tendons that form what's called the patellar reticulae, another word that's really difficult to say. You also have lots of these lateral ligaments that will extend from, say, the lateral surface of the femur to the tibia. So you have the tibial collateral ligament, and you have out at the outside, more lateral side on here on the fibia, you're going to have the fibular collateral ligament. Talking too much, I start tripping up my words after I've been talking for 2 hours. All right, here you have more live bones, so I like this picture a little better. Here we have our lateral condyle of our femur and our medial condyle of our femur. Remember, your tibia is your more medial bone, but the lateral part of the tibia will articulate with the lateral condyle. The medial condyle of the tibia will articulate with the medial condyle of the fibula. And you have your menisci that will run between these two collateral condyles, okay? And that's where it cushions and distributes the weight on those condyles. The fibula does not directly articulate with the femur. It articulates with the femur through the tibia, okay? So it's the tibia that's maintaining and receiving most of the weight. The fibula just helps distribute some of that weight down to the ankle. And here you see your anterior cruciate ligament. And because we're in the natural state, you can see how it runs kind of from this posterior edge on the internal to the anterior side of the tibia. See how it runs kind of through and is crossing right here, okay, with the posterior cruciate ligament that comes from this more anterior side and will then insert back on the posterior aspect of the tibia. All right. And when we're getting knee replacements for osteoarthritis, you see how the articular cartilage is ground down and you get some like little, you get lots of little osteophytes, little bumps and grinds from the grinding of the bone. And then they put a new smooth, shiny surface, metal surface with a ceramic surface to articulate below. And it's not as big as a hip replacement, but it will also have a stem, of course, putting this down into the bone. And that bone will grow around it and kind of incorporate into part of that synthetic material. And here is what artificial knees look like, okay? So you have your lateral condyle, your medial condyle. We kind of create a false meniscus, and you have your stem going down in the tibia. You see your fibula out to the lateral side. And here is a side view or lateral view in which you can see the patella resting over the top of this new articular surface of the femur. And see how the femur, when it moves and bends the knee, how it goes on this more sort of posterior aspect of this little fake meniscus. Okay, lots of effects of aging on our joints. We have different types of arthritis. Rheumatism is just a term, like remember you ever watched the Beverly Hillbillies and Granny always has her rheumatiz? So it's the general term for pain and stiffness in our musculoskeletal system. Arthritis means that you're having inflammation in one or more joints, and the most common is osteoarthritis. You live long enough, you're going to get some osteoarthritis, and it is caused by the wear and tear of joints, or it's a degenerative disease. So those of us who've been more athletic in our lives, whether it's athletic doing sports, athletic doing dancing, athletic doing gymnastics, you can get degenerative joint disease. You look at some of these old football players and they're walking around retired in their 40s and they're walking around like 80-year-old men, okay? This symbol, when I write 2/2, this is a thing everybody in medicine writes for abbreviation for secondary to, okay? So osteoarthritis is also secondary to many genetic factors that will affect your collagen formation, okay? We all can only do the best we can with the genes that we were given, all right? You know, my genes are never gonna make me an Olympian. I know that, okay? I do the best that I can on the genetic load that I have, all right? The cartilage on the end of your bones wears down over time, and there's really no cure. There's just the fix of getting a bone, you know, getting your joint replacements. The things they will tell you to ward this off as much as possible is staying active and maintaining a healthy weight, okay? Maintaining a healthy weight. The more weight that you put on your joints, the more you stress the joints. Here are some classic signs of arthritis. You get the inflammation of the joints in the hands here at your dips and your pips. So the joints in your fingers are your distal interphalangeal joints, and those are called your dips. Your proximal interphalangeal joints are called your pips, okay? When we get the nodes or the inflammation at our pips, it's called Bouchard's node. And when you get them at your dips, it's called Heberden's nodes. You don't need to know that, but I'm just telling you that. So this is what osteoarthritis looks like in the elderly hands. You've probably seen it on your grandparents or some other elderly person that you know. It's deforming a little bit. This is different from rheumatoid arthritis. Rheumatoid arthritis, you tend to get younger, and it's an inflammatory condition in which your own immune system attacks your joints, okay? It attacks the joints, and it tends to affect your small joints first, in the wrist and in the hand. And the cardinal sign of having rheumatoid arthritis over osteoarthritis is ulnar deviation. Ulnar deviation looks like this. Your joints start bending out toward the ulna. Remember, I said your radius stays with your thumb. That would be radial deviation if there was really such a thing. Ulnar deviation, your joints bend away toward the ulna. Other joint disorders is gout, okay? Gout classically affects the great toe first, but not always. And this is when uric acid crystallizes and deposits in the joints, okay? And it's We can draw it out in the synovial fluid, and it's due to a metabolic disorder that is beyond the bounds of this course. Pseudo gout is just like gout. You're depositing calcium pyrophosphate instead of uric acid crystals, okay? And these tend to not affect your big toe first. It affects some larger joints more typically at first. And both of those kind of have episodic flares. You can have sprains, which is a tearing of the connective tissue in your joint, okay? Or you can have bursitis, which is an inflammation of those bursa. And we typically treat that with steroids. Sprains you treat by rest, ice, compression, elevation. As Jaden was saying, ice treats just about everything orthopedic. Helps with that pain tremendously. Other effects of aging on your joints is that as you become more immobilized, you're reducing that flow of synovial fluid, right? As we move in that, and we don't squish our synovial fluid out of our joint capsule, but we squish it and move it all around. If you're not moving all that around, and you're not feeding all that synovial fluid on your articular surfaces. So when people become immobilized in the hospital, for instance, we put them on passive motion machines that will move their joints around for them, so it keeps that synovial fluid forming. And as we age, our bone mass decreases. We went through this with osteopenia and osteoporosis, which can also weaken your bone and increase the risk of hip fracture, because also you get a little bit more unsteady, your nerves are not functioning as well, and people fall down, and you fall